So, welcome. Welcome to Medical Mondays with Dr. O. Dr. Toyin Okpesomi, a physician in Maryland. I treat HIV with children, adults, anyone, every age, since I'm a family practitioner. I also treat drug addictions. And I'm grateful to be here today to continue our weekly sessions, Medical Mondays with Dr. O. I hope we all had a great time off last week to, acknowledge and just appreciate our veterans who put their necks out to give us the peace and what we enjoy here in the US. I'm glad we were able to take time off to do that. So this week, the third week of the month, is a day where our doctors and our DOs will get continuing medical education for participating in Medical Mondays with Dr. O. And they will be able to, say what they learn and, the regular process in continuing medical education. Participants also would be able to get certificates of participation. Please be patient. We're still working through the details of making this seamless, but we will get there. Without much ado, I'm going to introduce Dr. Oluwole Ajagbe, who is our speaker tonight. So the floor is yours, Dr. Ajagbe.
Good evening, everyone. I'm very excited to be with you today. But before going into the presentation, I just want to acknowledge Dr. O's birthday for today. We rejoice with Dr. O and we celebrate you on your birthday. It's kind of just surreal to see that the Medical Mondays with Dr. O falls on your birthday this year, and you didn't take a cheese break to say, hey, listen, let's cancel this because it's my birthday. So it's more appropriate to celebrate with you, to rejoice with you on a day like today. And more so that any presentation that would have been done today will have been worth 1.5 credit units for the medical doctors and the doctors of osteopathy. And so that's a way to celebrate somebody's birthday, isn't it? Anyway, so congratulations, Dr. O. May you continue to be blessed and continue to shine as you, give relentlessly and selflessly to the cause of humanity and also for the community that we represent. Thank you for sharing today with us. Otherwise, you should be sipping some pina colada somewhere.
Thank you so much. Thank you.
We just I wanted to take those few minutes just to acknowledge your sacrifice that you've been sharing with the whole world. So, ladies and gentlemen, I just want to say that it's
Dr. Ajay just posted a picture. We can leave it for later to give Dr. Ajagbe the floor. Yeah.
The reason I will kind of like for us to move along is because of the CME nature of today's presentation. If it was just a casual, other presentations, we could take 1 hour just acknowledging the birthday greetings. But for today, just for the sake of those who are not regular participants on Medical Mondays with Dr. O, who are guests today, who are physicians and DOs who are interested in getting the CME units, we will start the presentation, and I'll be sharing my screen. In 1 second, let's see if I can still share my screen. Start broadcast. Second screen. Broadcast. Okay. Can everyone see my screen?
Yes.
Yes.
Okay. So today's presentation is going to be on medical conditions caused by underdeveloped jaws. Well, let's go to the learning objectives for the sake of the professionals that are among us. There are 4 learning objectives that we will kind of just follow today, since this is a limited time type of presentation. So the learning objective number 1 is to understand medical conditions associated with with underdeveloped jaws. Second objective is to identify relevant diagnostic codes for these conditions. This may not mean much to the general population that are not doctors, but for doctors, I think this is very important, because once you have an idea of what the codes are, then it will be easy for you to say, okay, well, this is diagnostic code, and there has to be some kind of procedural codes that goes with the diagnosis. The third objective is to explore treatment options, including non-invasive appliances. And the last learning objective for today will be to review applicable procedural codes, that is the CPT as well as ICPICS for insurance reimbursements. So let's dive into the presentation today by just defining by way of introduction, the human jaw plays a critical role in overall health, including breathing, chewing, and facial development. Underdeveloped jaws can lead to a host of medical conditions, and dental treatments are necessary to address these issues, many reimbursable by medical insurance. So this presentation covers key medical conditions related to underdeveloped jaws, dental treatments, and medical insurance codes. So what are the causes of underdeveloped jaws? The first one that is undeniable is the genetic factor. That is, this is the genetic coding that defines the potential for everybody's development, particularly of the jaws. Because somebody has a blueprint of how the jaw should form does not necessarily mean that they will conform to that because of the environmental factors that mitigate or that influence the overall development of the individual's body parts. So let's say everybody, the genetic determination for every human being is that we should have 32 teeth as adults, as well as 20 teeth as babies or children, up to the certain age where we call the mixed dentition stage. For every child who is born of a woman, there's a chance that their baby teeth will be 20. And when they grow up to adolescence, the teeth will change from being baby teeth, which were 20 small teeth, to about 28 teeth that are bigger, much bigger than what the baby teeth look like. So what we see is that the chances are of these teeth coming out in the proper position will be limited if the jaws are underdeveloped. So today we're going to address some of these issues that actually develop from, that result from underdeveloped jaws that are untreated. So what are some of the environmental factors that actually modulates the genetic factor that determines the blueprint for jaw development? The main one that we should focus on is what happens to the baby as soon as the baby is born. When a baby is born and has no abnormality in terms of development inside the uterus, that is, the facial structures seem to be normal, what would determine the adequate growth of that baby will be the presence or absence of breastfeeding from the mother. If the mother has the adequate, tissue or, organ to feed the baby is bound to develop normally in terms of the jaw development and growth and the tongue as well. So if for any reason that newborn child was not breastfed, the problem now begins to cascade. First of all, if the jaw was narrow and with deep palate, the roof of the mouth is very deep and is very narrow. And let's say the tongue also is fixed, kind of fixed to the floor of the mouth, the problem becomes very obvious because the baby will not be able to breastfeed, even if the mother is able to breastfeed. If the baby is struggling to latch onto the mother's breast, you find out that the baby is crying, struggling because the tongue is fused to the floor of the mouth and the roof of the mouth is not broad enough to allow the suction or the vacuum that's supposed to be created for baby milk, for the breast milk to flow into the baby's throat, into the esophagus, so the baby can feed properly. When this happens, the baby feels, of course, the baby will be crying and the mother is frustrated trying to figure out what to do. Unfortunately, many times the mother would defer to using baby bottle, even if they are feeding the baby with natural breast milk and not formula. The baby is now unable to actually get the kind of stimulation that causes the tongue and the jaws and the muscles of the face to develop properly. So, absence of breastfeeding is a big problem, not just at the present when the baby needs to be getting good nutrition from the mother's breast milk, but more so for the future, because absence of breastfeeding will cause a lot of problems, which will stem from the underdeveloped jaws. The tongue and the suctioning mechanism for breastfeeding actually forms the environmental force that creates the normal arch of the upper jaw as well as the lower jaw for us to be able to grow and have our teeth in the right location with the right amount of spacing and without crowding and without what we call crooked arrangement or misalignment of the jaws. Now, once the baby is unable to breastfeed, and the baby goes to, the parents start using baby bottle, or, in addition to using the pacifier in between meals, this approach actually caused the jaw not to be developed. And things to make it worse is moving from feeding bottles and pacifiers to, Garba baby food, or the kind of baby food that are, already mashed together and blended and all smooth, that the baby doesn't even have any chewing capability in this feeding. That further worsens the situation that started from lack of breastfeeding or absence of breastfeeding. So most of the children that will go through this pathway of feeding in their early development will definitely have what we call malocclusion as a result of underdeveloped jaws. Now, what are some of these things that we will also expect to see in children with underdeveloped jaws? Mouth breathing in early childhood is a very dangerous thing for a child. Unfortunately, for a baby that has tongue tie and very deep roof of the mouth cannot close because the roof of the mouth is the floor of the nose. If the roof of the mouth is narrow and deep, it means the floor of the nose is being pushed up, which then means that baby's nose is very small and very narrow, even though the shape may look normal on the outside, but the space that the air needs to pass through will be very small. And many times these children experience the condition that is referred to as upper airway restriction. That is, they are making extra effort to get air through their nose. And when the air is being forced through the nose, the nasal lining, that is the lining of the nose, becomes irritated to the point where it becomes inflamed. And unfortunately, the nasal blockage becomes very obvious, and the baby now, by default, will breathe through the mouth. Now, breathing through the mouth is a very dangerous, option for a baby, because that causes the air going into the lungs not to be prepared for normal, perfusion, for normal gaseous exchange within the lungs. So what we're looking at here is a newborn or a child that is mouth breathing is going to have a lot of problems in the lungs because the air is not purified, the air is not filtered that goes into the lungs. And many times the air can can actually enter the airway with some drops or droplets of saliva, and that will cause the child to keep on coughing. And many times they get infection in their very young lungs. Another thing that can make underdeveloped jaw to be more pronounced is prolonged bottle feeding and thumb sucking, as well as pacifier usage. When a child in the first 6 months of age after being born doesn't have any access to breastfeeding, and they are on bottle feeding all day, all night, anytime they want to eat. Whenever they are hungry, they are on bottle feeding. Many of them in between will develop what we call parafunctional habits. One of them is thumb sucking, particularly if the parents do not give the baby a pacifier. Thumb sucking, pacifier, and prolonged bottle feeding, they are not conducive for proper development of the upper and lower jaws in a baby. Tongue tie, I already mentioned that earlier on, and an improper tongue posture is a result of tongue tie. One of the ways by which a parent or a mother can discover there's a problem with the baby is when a baby is having problem breastfeeding, and they are constantly irritated, and they regurgitate, or every time they try to suck, the milk comes out from the corners of their mouth. It doesn't mean that they are full. It just means that they do not have the proper tongue posture and the proper tongue function. And it's very easy to recognize for a parent. As the baby cries, look at the tip of the tongue. If the tip of the tongue is tethered to the floor of the mouth and the baby cannot lift the tongue up while crying, then you know that that baby has a tongue tie. Another way by which you can see it is if the baby is making tongue motions and you see like an indentation at the tip of the tongue, which makes the tongue, instead of being pointed towards the outside, there is a indentation as though the tip of the tongue was pulled backwards. That's a very obvious sign that that baby has tongue tie. When a baby has tongue tie and they have been on prolonged bottle feeding, as well as thumb sucking and any other parafunctional habits, as in the case of pacifiers, there will be a big problem in the future because the jaws will not form properly. We have already talked in passing about chronic nasal obstruction, which is as a result of small nasal passageway. Many of these babies, because they are already compromised in the way that they breathe, they are open to a lot of allergies, and that worsens the condition for that little baby. So when a tongue is in the wrong position and the jaws are misaligned, even with the baby teeth, there will be poor chewing habits, particularly, if they never learned how to chew anything because they move from baby bottle to soft baby food, which are already prepared in such a way that there is no chewing involved at all. So all these are the reasons why, underdeveloped jaw will lead to major, medical conditions in the future. Now, what are some of the symptoms that, the patient will, you can recognize as a parent or the patient will present with before coming to the doctor? The first thing that you notice is that that the teeth are crowded. If they are not crowded, just because of space, many of the teeth will be pushed out of line. So the teeth are not lined up in very straight, pattern, and they are referred to as being crooked teeth. TMJ pain, that is the joint. The lower jaw is the only movable part of the skull, and that jaw is hinged to the base of the skull. And when the mouth is open, the joint moves. When the mouth is closed, the jaw moves as well. So many times when the teeth, even as babies, when their teeth are misaligned, they bite wrong and they grind their teeth, whether they are asleep or awake. And this creates pain and dysfunction in the joints that we're talking about. Many children that have crooked teeth and have blocked nose or upper restricted airway will also be mouth breathers. And being mouth breathers means they will have sleep disorders, sleep disordered breathing. And until they are diagnosed as to whether they have obstructive sleep apnea, we can only say that they have sleep disordered breathing. So children that have underdeveloped jaws with crooked teeth, tongue tie, and a combination of all this will eventually have speech difficulties. They will have problems with swallowing and chewing. They will have, misaligned bites, which we already alluded to earlier. And then, of course, they will not look very attractive. Most children that are mouth breathers have very sad looking long face with the jaws, with the lower jaw, separated from the upper jaw, and the tongue, even though it's not hanging out, is occupying the space between the upper and lower teeth. Most of the time, this is not very attractive appearance for a child. So aesthetically, it is it's not very acceptable to parents. And many times the children are very, they feel insecure, they feel embarrassed among their peers. And, because many children, they have no inhibitions, they will tease them for their appearance. They think they are stupid. Even though their brain may not be, may not be affected by all of this, but their appearance will make them not to be easily acceptable to their peers. Aesthetically, it is something that, bring concerns to parents, and parents are always looking for solutions to that kind of a situation. Excuse me. Let's go back here. All right, so now let's move to what are the conditions, medical conditions that, I'm sorry, I'm using my phone and I hope everybody is still seeing my screen.
Yes.
Okay, so these are some of the medical conditions that are caused by underdeveloped jaws. Okay, so underdeveloped upper jaw, can you still see my screen?
Yes.
Okay. Underdeveloped upper jaw will cause what we call facial asymmetry. Sometimes it's only one side of the jaw that is affected, and sometimes it's affecting both sides. But even though it's affecting both sides, it will affect them, in a different fashion. So it's not symmetrically deformed, but you can see that the facial appearance is not equal. Usually, if you look at every human being, the left side of the face should always be like a mirror image of the right side of the face. If you look at an individual from the back, from the top of the head, and you see that one side of the face is bigger than the other, it means there is facial asymmetry. If they're not different by size, but by the deflection from midline, then we can also say there is facial asymmetry. And this is usually caused by underdeveloped jaws. When the lower jaw is exceptionally small compared to the upper jaw, the condition is called micrognathia. That is, the small jaw is actually what micrognathia means. The first terminology, which is maxillary hypoplasia, is a big word to say that the upper jaw is underdeveloped. The third term that you can see here, which is the third condition, is ankyloglossia, which is big word for the same thing that I've been describing as tongue tie. This is when the tissue that hold the tongue to the floor of the mouth is very short and very tight, and is quite thick enough that the tongue is tethered to the floor of the mouth and the tongue cannot be lifted up to be in the normal position at rest. The normal position at rest for the tongue is gently resting up on the roof of the mouth, which is broad and wide, and relatively flat. If the roof of the mouth is deep and narrow, the tongue cannot occupy the right space. So the tongue will always assume a lower position in the mouth at rest, which is the reason why the child or the individual will be a mouth breather because the jaw will be apart. Orofacial developmental disorders, that's a big word to mean that the mouth and facial developmental disorders and anything that affects not just the jaws, not just the tongue, but affects other parts of the face will have formed about the same time the upper and lower jaws were forming. And that is what is classified under the orofacial developmental disorders. So some of these things will maybe things like facial clefting, maybe, other structures that are missing that will cause abnormality of the face and the mouth. Another condition, medical condition that results from underdeveloped jaw, and as we've discussed, will be airway obstruction. And when it occurs intermittently during the night, when there's intermittent obstruction of the airway during sleep, while the individual is sleeping, and it can be recognized first by the fact that the individual is breathing, the chest is rising, but there's no air passing through the nose into the lungs. In that situation, the brain wakes the individual up in such a way that the individual will not be fully awake, but they will be aroused enough to move in order to open the airway. And when that happens, the individual is referred to, when it's diagnosed, actually, is referred to as having obstructive sleep apnea. The obstructive sleep apnea is as a result of developmental abnormalities that result into structural defects that only results into partial or complete obstruction of the airway, whether the patient is awake or asleep. So this is another slide just to reiterate for the sake of our medical professionals. These are things that you might need to be familiar with if you're going to be recognizing some of these conditions. These are the ICD-10 codes. So for the impaired airway function due to narrow jaws, the diagnostic code is G4733. So if you know that when you observe a child that has, or an adult for that matter, that has a diagnosis of obstructive sleep apnea, this is the code that the insurance will expect us to use, when we are filing a claim, whether for treatment, intervention, or for diagnosis in terms of patient care. Temporomandibular joint disorder, or TMD, the ICD code that we use is the G50.1, and that is what the insurance company will recognize as being adequate documentation and recognition of the condition that needs to be treated. Chronic sinusitis and breathing disorder, difficulty in breathing, nasal congestion, and chronic sinus inflammation and blocked nose. The codes for that will be, as you can see, ICD-10 will be J32.9. So when we recognize all of these things and we use these the codes, we can adjudicate our claims very successfully. So these are some other codes for orofacial conditions that the medical doctors need to become familiar with. Maxillary hypoplasia, micrognathia, ankyloglossia, orofacial developmental abnormalities. The ICD-10 codes are all there. Obstructive sleep apnea, as we talked about it earlier in the previous slide, TMD, malocclusion, primary care physician, pediatricians, and specialist doctors can actually recognize all of these conditions, even though they are not going to be the ones to treat them, but they can refer the patients to the appropriate specialists that can help the patient get an excellent, treatment outcomes. So this is the reason why I'm sharing all of these conditions with their diagnostic codes. So what happens if for any reason these conditions were not recognized? If they were not recognized, they would not be diagnosed. If they were not diagnosed, that means they would not be treated. So what happens when underdeveloped jaws are not treated? So the first thing that we're going to see, as I've already talked about, this is going to just be like a reiteration. Crowding of the teeth will often lead to crooked arrangement of the teeth and will also, lead to, misalignment of the jaws, which is what we call malocclusion. Any child that is a mouth breather stands a great, higher risk of developing frequent and multiple dental decay of their teeth, because as they open their mouth to breathe, they form more plaque more readily. And also the plaque is the reason why there is gum inflammation that leads to gum infection. Also that, many cavities will develop in the teeth of the individual. So upper airway restriction syndrome, we've already talked about that. These are things that will result if the underdeveloped jaws are not treated the way they should. Chronic sinusitis, allergies, tonsillitis, and adenoiditis, middle ear infection, TMD, and obstructive sleep apnea. Now, let me spend a few minutes on tonsillitis and adenoiditis. Some people will call it adenitis. Every child that has upper restriction airflow will be a mouth breather. And every child who is a mouth breather will have constant inflammation and infection of the tonsils, which are like gatekeepers of the throat for infection. They try to capture every kind of infective agent because they are lymphatic tissue or lymphoid tissue that actually are like our defense mechanism against, foreign agents like bacteria or chemicals. And once the tissues of the tonsils and adenoids are overwhelmed, they will become hyperplastic, they become swollen, they become enlarged. An individual that already has a compromised respiratory condition will be worse with the enlargement of the tonsils and adenoids, because they come together and further close the airway and make it so narrow that the child or the individual will be struggling to get air through. Many times these individuals cannot swallow properly. They have problem even talking. And they have, lung infection because of the way the air going into their lungs is being prepared. So if a child has had multiple tonsillectomies or adenoidectomies done, it means until the root cause, that is the foundation, the foundational cause of the problem is dealt with, the tonsillitis and adenoiditis will continue to form because if the child continues to be a mouth breather, there is no other way for the airway to be purified other than through the tonsils and adenoids around the throat. So another thing that most of these individuals who develop will be middle ear infection, because the throat, there is a connection between the middle ear and the throat. We call the tube eustachian tube. And that eustachian tube, when the opening into the throat is blocked, the drainage that's supposed to take place from the middle ear into the throat will become stagnated. And once it's stagnated, it causes a lot of big problems. Not only just infection, it causes imbalance because of the differential pressure on either side of the eardrum. And unfortunately, for some of these children, when there's accumulation of pus that cannot drain through the eustachian tube, when it's accumulated, it can only perforate the eardrums, and that causes a big problem on its own. So middle ear infection is something that we cannot overemphasize, and we cannot overlook it as well. We should pay attention when a child or a baby constantly rub their ear or put their fingers or their hand on their ear. We should suspect that something is going on, and if the baby is running temperature, the pediatrician needs to be consulted with, and then if they need to refer the baby to an ENT surgeon, so be it. But the child that is going through these complications of untreated underdeveloped jaws these individuals are not happy. They're constantly sick, they're constantly weak, they're constantly uncomfortable in every way possible. So this is the reason why we cannot overlook or, we cannot do anything but to recognize that there's a major problem when we see any child with jaw underdevelopment. Now, one of the things I want to talk about before I go into the treatment options is the fact that when a baby, from 6 months to about 3 years old, if you observe that the baby teeth are crowded, baby teeth are very small. If the baby teeth are very crowded, even as early as 3 years old, it means that child is behind in the jaw development department. So if you ignore that, as soon as new adult teeth begin to show up, there will be severe crowding. Unfortunately, these individuals or these children will be exposed to having a lot of extractions done. There are ways by which we can avoid all these invasive procedures if this can be recognized early, and there are early interventions, that are brought to bear on behalf of these children. So now let's take a look at what the treatment options are. For children that are, between 6 months and 3 years, that we observe that having having a space problem, particularly if their baby teeth are crowded already. In order to encourage growth, there is an approach that we can take to help that little child. The device that is being used is a removable appliance, which is called a growth guidance appliance. There are many manufacturers of this, in that we can, the right professionals can prescribe this for the children, for that individual or that child, in order for the jaws to be encouraged to grow to full capacity. So growth guidance appliance is the first line of action or the first option for a little child between the ages of 6 to 3 years old. For other children that are above, 3 years old, they can actually, benefit from rapid maxillary expansion device, which is for them, if these are children that are very uncooperative, they can be fixed. But if they are children that are very compliant, they can be removable, and the parents can supervise the use of this device. The Schwartz appliance is similar to the rapid maxillary expansion device, which is, a removable type of appliance that can be worn, but adjusted, by an adult in order for the action to be realized to grow the jaw by stretching the joints as there's a small screw that actually advances the growth of the jaws. Mandibular advancement device. This is a device that is actually used for those children or adults that have obstructive sleep apnea because of the way their tongue falls to the back of the mouth, of the throat during sleep. This is this is a removable appliance that the individual will wear at night to sleep. The appliance is adjusted in such a way that the lower jaw, that is where the tongue is attached, is moved forward beyond the normal location at rest. And that the mouth is also kept a little bit separated, that is upper jaw and lower jaw are separated a little bit to allow for air to go through in case the individual has a nasal blockage. So that device is a device that is, that's manufactured or custom fitted to that individual, and it cannot be, bought over the counter, or be done by DIY, do it yourself kind of approach. This is supposed to be, customized for each individual, and it cannot be shared among members of the family. So it is best for us to understand this. This is not one of those devices that you say, well, don't they sell it at CVS or Walgreens or whatever? If you try to do this on your own, it may be more dangerous for anyone who is trying to do this do it yourself kind of intervention. For children that have a tongue tie, there has to be a corrective surgery. It's a very straightforward and simple surgery of what we call frenectomy, or tongue tie revision, and this can be done by most dentists or oral surgeon, or some dentists who are specialized in the area of airway-centric dentistry. Excuse me. So the last option that I've, non-invasive option that I wanted to talk about, without mentioning the name of the manufacturer, because I'm actually not representing any vendor. Neither am I, accepting any honorarium from any of the vendors of the appliances that I'll be talking about. So the BOAT, it stands for Biomimetic Oral Appliance Therapy. This is where epigenetics is being utilized through certain appliances that creates almost normal, environments for stimulating bone growth. So the DNA appliance, the DNA does not stand for the same kind of DNA in terms of genetics. DNA here stands for day and night appliance. Day and night appliance. It is not the deoxyribonucleic acid, which is the genetic coding that we have in genetics. So the second one, which is also not related to genetics, is mRNA, which means mandibular repositioning night appliance. So this one is similar to the number 4, which we call the mandibular advancement device, except that it has a way to be adjusted to grow the jaws as well as advance the lower jaw forward to clear the airway when the patient sleeps or when the individual sleeps. So these are the non-invasive approaches, except for the last bullet, which is the corrective surgery. When all these options fail, then the only way to help the individual, apart from the use of CPAP, which is the machine that opens the airway, particularly for those people who are suffering from obstructive sleep apnea. If all of these devices are not available, the first line of treatment for people with obstructive sleep apnea is the CPAP, which is the continuous pressure appliance that opens the airway, that actually allows the individual to breathe with all the facial mask or nasal cannula that prevents the individuals from stopping to breathe. From having the intermittent interruption of breathing during their sleep. So that machine is imperative for any individual that has a diagnosis of severe or even moderate to severe obstructive sleep apnea. So before any other option can be explored, they must be on that, CPAP first, in order for them to at least get enough oxygen into their brain and other parts of their, other tissue and organs of the body. So let's quickly go on to, well, just for the sake of the, the doctors, I wanted to go into some of the CPT codes that are being honored by insurance, payers, when we file our claims and we do treat these patients for this type of, conditions, using the different kind of appliances, there are, CPT codes that can be used by dentists in order for them to get the claims processed successfully. For jaw expansion, the CPT code, is written on the slide. For those who are interested in the biomimetic oral appliance therapy, which grows the jaw, as well as the airway opener, the CPT codes are also there. Many of the medical insurance payers actually honor this CPT code as if the patient has coverage in their insurance policy. So additional treatment options that we use to help people that have underdeveloped jaw that are undergoing treatment is what we call the myofunctional therapy. Myofunctional therapy is usually, sometimes it's done by people, providers who do the speech pathology or who do functional therapy, occupational therapy. Some chiropractors may also do them. Hello? Hello? Can you hear me?
We can hear you. Sorry about that. I'm trying to get the person.
Okay. All right. So anyone who has been experiencing wrong tongue posture or has had tongue tie or, has narrow roof of the mouth and the tongue has never reached the roof of the mouth to create that seal, in order for them to assume the correct posture, they have to go through this myofunctional therapy. And the myofunctional therapy is a series of exercises that they will be guided through by the specialist in order for them to position their tongue in the right places and in the right place for them to be able to function appropriately. Now, we've already talked about the tongue tie. We cannot overemphasize that if any individual has tongue tie, whether they are children, babies, children, or adults, and they've been having big problems without knowing that it has anything to do with the tongue tie, once this condition is diagnosed, it should be revised, and that means the frenectomy should be done in order to improve the function that has been impaired all along. So surgical intervention for severe cases may require, severe cases may require, surgical corrective, corrective surgical intervention, in which case an orthodontic surgery will have to be performed by an oral surgeon. So here are some of the codes again, just for iteration. Anyone who is interested, after the presentation, I can make this available to Dr. O to share to anyone who is interested. So now let's quickly go over what the insurance, maneuvering is all about. Treatment for underdeveloped jaws are often medically necessary. But unfortunately, most of the time, they are not diagnosed by the primary care physician or pediatrician. And when they are not diagnosed using the correct ICD-10 code, the insurance company would not see the reason why they should treat that patient. Even if it is raised by the parents, the insurance company will say, well, there is no diagnosis. If there is no diagnosis, then there will be no need for any kind of treatment proposal or treatment plan for that individual. So this is the reason why it is important for the condition to be recognized by all providers, all medical providers, and so that once the diagnosis is done, treatment, will become very easy to be, actually presented to the insurance in terms of predetermination, and the insurance will consider if the individual has coverage or not. If the policy does not cover such, well, they will say, well, they are not objecting to the treatment, but that the individual does not have the appropriate insurance policy for them to be able to pay for the service that is needed. So I've experienced that with some patients, that the insurance will say, we are not denying the treatment for the sake of medical necessity, but we are denying it because the patient does not have appropriate, coverage. The conditions like sleep apnea and TMJ are, usually covered by medical insurance. Once there are, once there are justifications for it, based on the narratives that are submitted with the predetermination request, the insurance reviews, and they usually will approve the treatment for such. For dentists, if there's any dentist that is participating tonight, if you are seeing patients that have jaw underdevelopment or underdeveloped jaws, it is imperative for you to document it in a very systematic way, just in case the primary care physician or pediatrician will need help in order for them to, write the letter of medical necessity to the insurance to justify the need for that individual to be treated. And sometimes the insurance will also ask the dentist to submit a letter of medical necessity to justify the treatment that will be planned for that individual that has underdeveloped jaw. Pre-authorization may be required for certain procedures, but I'll take that back. I'll edit that to say that almost any major treatment that involves payment of insurance the insurance will request for prior authorization, unless it's expressly said in their policy that this particular treatment is already covered and does not require predetermination request or approval. Then one can continue or proceed to treat the patient using that treatment modality. So these are some of the things that the insurance will request. They request for documentation of medical necessity. They request for detailed treatment planning. And they want us to request from them prior authorization before we do anything. They want to know the provider's credentials. They want to know that the patient is eligible before they can give any kind of approval. And another thing is, for many patients that have obstructive airway, the insurance wants to see a positive sleep test result. If the test result, if there is no sleep test, the insurance will not even consider any sleep disordered breathing as anything to be funded or to pay for. So there has to be a sleep test done, and usually the sleep test result will give an AHI score, and the AHI score will either be mild, moderate, or severe. Any individual that has moderate to severe, as soon as the diagnosis is done and the insurance gets it, they usually do not hesitate to authorize the use of CPAP. So that's a different topic for another time. But anyway, so positive results of Epworth screening assessment is also sometimes requested by some insurance companies. Not all of them request exactly the same thing, but there are certain things that overlap on this list that the insurance companies will request. So what are the steps for providers, for successful prior authorization? The first thing is to collect relevant patient data. The next thing is perform diagnostic tests, which may require imaging. For instance, as a dentist, if I'm trying to work with patients with airway obstruction, I will request a CBCT with the airway volume, upper airway volume measurement before any kind of intervention is planned for that individual. Many times, this is reported by the radiologist, and it shows that there is a constriction of the airway, and that is something objective enough for the insurance to review and approve for treatment or intervention. A draft of comprehensive letter of medical necessity should always be on hand, just in case you have a patient with who have the criteria for the kind of treatment that we're talking about. So anytime the prior authorization request is being submitted, it has to be submitted with all the supporting, documents. And we need to follow up with insurance, because many times insurance companies are not quick to respond, but we know that many of these individuals need help real urgently. And so we will follow up with the insurance company as needed. And many times the insurance company will respond once they find out that the provider is not relenting in trying to help the patient to have a better quality of life. So in conclusion today, underdeveloped jaws cause a range of medical conditions, but proper treatment can result in significant health improvements. Many procedures are covered by medical insurance when deemed medically necessary. Collaboration between medical and dental practitioners or providers ensure comprehensive care for the patient. So these are the key takeaways for today. As we have gone through for the past few minutes that have been sharing with us, I want to just key in on some of these takeaways. And this is the first one is early identification and treatment can prevent complications which may not only be very complicated or complex in the future, but also may be very, very expensive in the future if it is not taken care of early. Accurate documentation ensures insurance reimbursement. That is, if the patient is eligible for such treatment under their policy, then once the insurance companies want adequate and accurate documentation of what the condition is and the treatment planning and all the other supporting test results. Collaboration between dental and medical professionals is very, very crucial. And that's because this approach is patient-focused. It's not, specialty focused. It's only focused on getting the patient the optimum, treatment that will bring about the excellent, treatment outcomes for that individual and the family. Then we must stay updated on treatment options and insurance coding. Since we know as doctors, we know that they're constantly changing things on us. Before we know it, you are learning ICD-10. Before you know it, they'll say, oh, by the way, in a few months' time, there's a new ICD coming out. They may say ICD-10B or 10A or, whatever. So we don't have a choice but to keep abreast of what is coming up the pike, and any changes we need to be aware of. And of course, if we need special help from some consultants who are specialized in some of these resources, we need to draw on those resources. At this point, I will stop, and I hope I haven't bored anybody too much, but this is the time for question and answer. Thank you for your attention.
Thank you so much, Dr. Ajagbe. Very technical tonight, but I hope our audience was able to get something out of it. So your take home, what is your take home? You talked a lot about CPT codes and ICD-10 codes, which most of our audience would not comprehend. But what is your take home with, children? And now there are lots of adults in the audience, and some probably have underdeveloped jaws and have sleep apneas. So what's your message to them?
Well, I apologize for the technicality, for the technical nature of the presentation tonight. I try to balance between the requirements for the CME presentation and be able to make it at least user-friendly for those who are not doctors. I apologize. I didn't have a choice but to share some of those details because they are part of the learning objectives that I predetermined for this presentation. However, based on what Dr. O just asked, the first thing I will say is this: let's become self-aware. I'm not saying become paranoid about every little thing, but to become self-aware means look in the mirror. What do you see? Is one side of your face different from the other side? What is the difference in the shape or the size of your face? If you draw a simple line in the midline, invisible line, and you can look at in the mirror, you look at the left side and look at the right side and see if they are almost like mirror image of each other, then you know that you don't have facial asymmetry. Now, if you look in the mirror and you look at your teeth and your teeth are all crowded, automatically you know that you do have small jaw in relation to the sizes of your teeth. So if your teeth are too big and are too many for the space that you have on your jawbone, then the teeth have no option but to climb on each other in a crowded form. And if you open your mouth, you see if your teeth are lined up straight or not lined up straight. It is not a matter of, in our family, we always have very good teeth, we have very bright teeth, we have straight teeth. But I say to you, look in the mirror. Take a look at some areas of your mouth that you've been having problem with. Sometimes if you move your tongue around your teeth in the back, you will find that some teeth are worn down more than others. Anytime you find a tooth, particularly on the lower jaw, that is flattened more than the others, it means originally that tooth was malaligned. That is, it was not lined up properly, either in angulation or in line on the jaw in relation to the upper jaw, upper teeth, or the opposing tooth. When you see that, observe, have you been having headaches? Have you been having jaw aches? Do you wake up to pee frequently at night? And you get to the bathroom and all you do is just few drops, and then you go back to sleep. And if within a few minutes you wake up again and go back to the same thing goes on. It doesn't mean that you have problem with your kidney or your bladder. It only means your body, your brain is trying to wake you up so you can breathe. Many times people don't realize that it is because they stop breathing that the brain wakes them up to go and use the bathroom. Because the brain knows that once they get up, they will breathe. For some people, it is the fight, fright, or flight mode that they get into is a reflex. When the brain wakes them up from the intermittent interruption of breathing, they wake up. They are not fully awake, but they go into this stress mode by clenching their jaws. And when they clench their jaws, they don't just clench vertically, they twist their teeth as they grow, as they clench down, because they're not even conscious of what they are doing. They have no idea they are doing that. Only when they wake up in the morning, they might say, whoa, how come my jaw hurts? Oh my gosh. And they touch their temples and they say, wow, this place hurts. And many times people will wake up very weak. Many people will wake up very drowsy and very confused. And many times people wake up with headaches and with very irritable. And it's been found that many of the road rages are related to those who have had sleep disorders. So when you find somebody cutting you off early in the morning because they woke up late and they are very irritable and they are very jittery because they know there's a consequence for their lateness or wherever they are going, they will do all of these things. And if you challenge them, they're ready to fight. So some of these things are related. If you find yourself in this kind of vicious cycle, the foundation may be, I'm not saying all of them is, The foundation may be that your crooked jaw, your crooked teeth is causing you a big problem. Now, I didn't say too much about aesthetics. I mentioned it earlier on, but if you look in the mirror and you don't like what you see, well, ask for help. You don't like what you see, I think I should look better. What should I do to look better? Then seek help. All right. If you know you have been choking a lot, every time you drink something, you choke. You drink something, you choke. You don't think there's anything wrong with that. I say, why am I always choking when I sip something? Well, could it be that your tongue is tied? If your tongue is tied to the floor of your mouth, it does not move to the roof of the mouth to create that seal for you to swallow, which then means if there is no controlled swallowing, the fluid can go anywhere. And if you are breathing in at the same time that you are swallowing, the chance that you're going to inhale some of that fluid that you are swallowing. So these are the things that if you observe all of these things in yourself or any member of your family, it shows that there will be need for help.
Thank you so much. That is so helpful, I'm sure, for, a lot of our participants, because, we hear about the children, this started in childhood, but what about now that one is grown? And so thank you for shedding more light into that. Dr. Izugu, you have your hand raised. Kindly ask your question.
Yes, thank you, Dr. Ajagbe, for that presentation. Extremely very informative. And also for explaining the DNA and mRNA so that we all understand that it's not like you're going to get them to have new genetic teeth or mouth or something. But in any case, in following up with this question about children, many a time we see in clinical practice, they're in the 20s now, and now they're having palpitations and heart issues. Mm-hmm. Could you comment on heart issues that could happen with this situation? And two, could you also, because sometimes when we meet them at this age, they say, "Oh, we had a test done. They said they had mild sleep apnea 5 years ago or something," so they didn't make much of anything like that about it. If you do a sleep study and it's mild sleep apnea, when is the next appropriate time to recheck it to see how it's going? And also, what's the best advice to give to those patients so that they can know that just because it's mild today doesn't mean that it's going to be mild forever? Because to us, sleep apnea is like being pregnant. It grows, And last but not the least, some of the patients, they have moderate sleep apnea. Let's say they have CPAP machine. And for some reason, they have their follow-up sleep study, which is appropriate, just to retest them. And now they have mild. And some of them will stop using their CPAP machine. Can you comment on the appropriateness of their doing that? Or what is the best advice to patients to know and how, on these issues? Thank you.
Thank you, Dr. Izugu, for the question. Let's look at it from this standpoint. Any individual that has underdeveloped jaw that causes upper airway obstruction will develop cardiovascular complications, sooner or later. If they don't have it right now, they will eventually, because everyone that has obstructive airway that presents itself as obstructive sleep apnea, whether it is mild, moderate, or severe, are going to be experiencing some kind of desaturation, if I can use that big word, which means their oxygen tension will be lower up to the level that is very critical. Most times that they stop breathing. The critical point for oxygen desaturation is 82%. Anyone that goes below 80% is going towards irreversible brain damage. So that's the reason why anyone who stops breathing for up to 10 seconds, the brain will arouse them to move so that the airway can be opened. So if a patient is already having palpitation, having all the cardiac events, it then means that they need some form of intervention to prevent them from continuously having, even the mild sleep apnea can precipitate, cardiac events. So CPAP is the first line of action, although many insurance will not pay for CPAP for mild sleep apnea, because they will say it's not serious enough for them to pay for the CPAP. But any individual that has intermittent, desaturation of oxygen in their brain will eventually have cognitive problem. It doesn't matter how infrequently they are experiencing this, because the brain needs constant supply of oxygen at the optimum concentration. So if anybody says, oh, the diagnosis was mild and they don't want to do anything about it, well, the consequences is cumulative over time, cumulative. Now, if the insurance doesn't pay for CPAP for a mild diagnosis of CPAP, my diagnosis of OSA or obstructive sleep apnea, then the underlying cause should be looked at. How is the jaw? How is the upper jaw? Does the upper jaw have narrow palate, very deep, narrow palate? If the answer is yes, and the individual is constantly having sinus problems, constantly having nasal blockage, constantly having allergies, constantly having, if some of them will have asthma, if all of these are present, it means if you don't take care of the underlying cause, which is the jaw underdevelopment, that individual will only be treated symptomatically, and they will have relief, and they will have relapse, they will have relief, they have relapse, and that's not going to help them long term. So the answer, this simple answer to that question is the underlying cause should be addressed. And I'm sure it has to do with the foundation, which is the jaw formation, and that needs to be corrected. Now, for those who had moderate sleep apnea diagnosis, and they use their CPAP for a few months, and they say, okay, go back to do a retest, and the retest says, now you are mild, and they say, yay, we got some good success. Well, if the mild is still on the, on the borderline, of more than, 5 interruptions per hour, because think of it, what is called mild is 0 to 5 interruptions per hour. So if somebody is still having 5 interruptions per hour and they sleep for 8 hours, it means they have stopped breathing intermittently for 40 times. If they stop breathing for 40 times for about 10 seconds and their oxygen saturation goes to 82%, that is not good for any brain that is developing, particularly if it's a child. So this is the reason why the correction must be put in place so that these interruptions in oxygen saturation should not be persistent. So now, for those who have severe diagnosis of sleep apnea, and if they move to moderate and they say they don't need this CPAP anymore, well, unless they do the correction and have a permanent airway opening, they will continue to have problems. One of the problems that they may be having is the when they have reflux, every time they stop breathing, that is, when the airway is blocked, they are making motions like they are breathing, but the air is not passing through. There is a back pressure that is created in the pharyngeal area, and that area, that causes the contents of the stomach to back up into the throat. So that is called reflux. Many times people will wake up and they feel that their mouth tastes sour. When it tastes sour, it's because some of the acid content in the stomach escaped right into the throat and eventually flows to where the tongue is. And of course, since the tongue falls to the back, when the individual falls asleep, some of this content will be in the mouth by the time they wake up. So this is a sign that whether they stop, whether there's a little improvement in their AHI score or not, if they are still experiencing acid reflux, they cannot stop using the CPAP. They should not stop using the CPAP, because that means they are still having, anyone who has moderate, which means they are between 5 and 15 times per hour that they stop breathing intermittently. Anyone who goes beyond 15 times interruption during sleep per hour is already on the dangerous ground. So most of the time, the diagnosis of severe, is up to, 30 times per hour that they have interruptions in their breathing. So anyone who stops breathing 30 times per hour and sleeps for 8 hours means they have stopped breathing for 240 times. If you multiply that by 10 seconds, that's a lot of time that the brain didn't get enough oxygen. So the thing is, let me even address the fact that majority of the people that have severe diagnosis of obstructive sleep apnea, they are non-compliant with their CPAP because they say they are claustrophobic, it is very uncomfortable, they cannot roll over, they cannot do this, they cannot do that, so they do not even use it. I have patients that will come to me and ask them, so how's your sleep? Say, I'm afraid you will ask that. I say, so what's been going on? Say, well, I don't like my machine. I don't like to use it. I said, but how does that affect you overall? If you don't use your machine, don't you realize your brain is not getting enough oxygen? I know it, but it's uncomfortable. I wish there was something else. And then we'll tell them, well, the other option is you have to intervene, you doing whatever the foundational problem is. At this point, many of them are adults. They are not qualified for insurance coverage for any of these devices.
Right.
So if they're not there, it's now a question of do they have the funds? Can they afford it? There is no shortcut to that. If they have tongue tie, if they have narrow, deep roof of the mouth, and they have big tongue, one other thing that people should look out for is when you stick out your tongue, if you see the indentation of your teeth on your tongue, that is, you see all your teeth have put impressions on your tongue, it means that your tongue does not have enough space. If your tongue does not have enough space, it means every time the tongue relaxes, it goes to the back of the throat. And if it's big enough, it can block the airway that you will have to be the one to make effort to open the airway. So those who have CPAP and don't use it, is a very dangerous thing. If you need it, you should use it. If the face mask is not working for you, ask your provider for an alternative. There are nasal cannulas now that can do the same thing. They're not as cumbersome as a face mask, but the danger is if you're a mouth breather. So how do you deal with that? The face mask is still going to be your default if you are a mouth breather. Everybody must choose to be a nose breather. Everybody. Anyone who does not have by default a nose breathing is going to have problems. It's going to continuously have sore throat. If they don't have sore throat enough, they will have tonsillitis, they will have adenitis, they will have chest infection, throat infections, all kinds of things will be going on as mouth breathers. So a lot of the people that have CPAP are mouth breathers, and it's a very dangerous thing for them not to even use the CPAP when they fall asleep.
Thank you very much. Thank you.
Thank you very much. I have a question in the chat box. It says, if part of your frontal teeth broke off, but doesn't disturb your eating, and the base of the teeth is solid, do you need to do anything about that?
Well, the simple answer is yes. If the teeth, the opposing tooth is expecting that tooth to touch it. So if you have an upper tooth, whether it is in the front or in the back, if there's a gap and the bottom, let's say there's one tooth missing and the other teeth are touching when you close your teeth, when you close your jaw, the unopposed tooth will attempt to overgrow the others to try to touch something. So if you leave it for an extended period of time, eventually you find out that one tooth that's supposed to be opposed by the missing tooth will begin to be taller. If it's on the top, it will continue to grow down until it touches something. If it doesn't touch something, it will continue to be like it's getting longer and longer than the others, and that will cause you problem eventually when you chew. If it's in the front, if cosmetic or aesthetic is not your concern, well, I mean, it doesn't affect your chewing or biting, go for it, leave it alone. I mean, if you don't want to do anything, nobody can force you to do anything. But if you, it would not prevent you from doing the simple things like chewing and all of that stuff. If it's only the front tooth, I'm saying. Biting may be awkward, and cosmetically it may not be acceptable to you. And if that's the case, even just for the cosmetic reasons, you want to restore that tooth.
Thank you so much. Wow. Thank you for bringing this to light, because we've asked you about this, how we can help our patients, especially from childhood, with getting the right care, getting them to the dentist or orthodontist or who they need to grow the jaw, which is the time that it should be done. And we've discussed about how insurance will cover this, because whether we like it or not, we still have to bow to the insurance companies. And what you have presented tonight is invaluable, because a lot of us have learned, the codes needed, what to look for, and how to navigate that so that we can get the help our patients need for them. And again, getting them when they're babies and when they're children is better before people become adults and insurance is not going to cover it. So thank you very much. We appreciate you. The audience have spoken also on the platform that they actually get it. I was worried that only we doctors will get the most benefit of this, but our audience actually also understood. We appreciate you very much. So if you give us your closing remarks, take home for us to take home, that'd be great so we can end the CME segment and take you off the hook.
Well, thank you for your attention, everyone that is still here. I apologize again for those who felt this is too technical, too many big words being used. I try not to use too many big words, but there are certain things that we cannot avoid using if we're going to communicate to professionals that need to get the credit. So I will still maintain the same thing, that become self-aware, check in the mirror. If you have minors with you, check them. Children, babies, grandchildren, great-grandchildren, anyone that you have charge over, check them. If everything looks fine, that's fantastic. If they're not optimum, seek help. At least seek help. Let somebody tell you, I can't do it, but let me find somebody who can do it for you. All right. So without asking, you would not get the kind of help that you need. If you have teenagers, but they are not 19 years old yet, many of the dental insurance policies will cover them for orthodontics. Orthodontics is alignment, treatment process to align the teeth that are crooked. Unfortunately, there are two kinds of orthodontics. I say unfortunately, in the sense that one of them requires some teeth to be pulled, while the other one does not require any tooth being pulled. The one that doesn't require any tooth being pulled is not as popular as the one that requires teeth being pulled. And things are shifting. And that is where I come in, that I prefer not to pull any tooth. I prefer to create space for all the teeth. And if there are devices to bring that to this forefront, why can't we do it? So that's the reason I feel that any child that is below 19 should seek help. The parents should at least go look for help. If the orthodontist says, well, we have to extract 8 teeth, wow. You might say, no, is there no other alternative? Do we have any other treatment that can keep the teeth in place? If he says, I don't know of any, well, call another orthodontist, ask them, do you do retractive orthodontics or you do expansive orthodontics? So retractive orthodontics is the one that everybody knows. The braces, the wire, everything is being pulled backwards, so it's retractive. Expansive allows your jaw to grow forward and downwards. That is the best position for your jaw to be, forwards and downwards. If it's going backwards and upwards, that is not going to serve the child very well. If after taking out 8 teeth, the child still has tight fitting teeth, it means there's really no foundation for all of the teeth that the child has. The child has a blueprint genetically for 32 teeth. But the jaw is not growing to its full potential to accommodate 32 teeth. So which is a sad thing, but now we have technology that can actually do that. That can actually encourage the jaws to grow to full potential, that you don't even have to extract any tooth. Now, how to navigate it is what we've talked about. If the diagnosis is made correctly, the medical insurance has a letter of medical necessity to justify the treatment. If the treatment will cost $20,000 and that child's parents have insurance policy that makes that child eligible, they will pay $20,000 for that treatment. But if it is going to dental only pays up to $2,000 a year. That's the highest that most dental insurance will pay. So that's why my presentation tonight is to help you or anyone listening that you can actually see how you can get the benefit that you need through the medical insurance. But the right diagnosis must be in place. If the diagnosis is not there, the insurance will not even look at your interest. So please become self-aware and become aware of the people under your charge. And if there's any question that I can answer, you can reach out to me through Dr. O, and I'll be glad to answer them for you. There are a group of dentists now that are becoming what we call the airway-centric dentists. Airway-centric, that is, our focus is to make sure that the airway is open, because we know that if the airway is not open, it affects every part of the body. The whole system of the body is affected. And the jaws and the mouth are the gateway to the overall quality of health.
Thank you. And when people use braces, after the braces are taken out and all of that, then they have to forever use retainers.
Mm-hmm.
You have to use those, take them out when you want to eat. Well, getting to the root cause, I agree, is always the best thing to do and fixing the underlying problems. Dr. Fawole, kindly unmute and ask your question. I'm sorry, Dr. Ajagbe, you've given your parting words, but I have a hand raised, so we don't leave any questions unasked.
Thank you so much, Dr. O. Happy birthday again.
Thank you.
And thank you, Dr. Ajagbe, for the insightful presentation. I just have this, and I know you might not have an answer to it tonight, but you guys are trailblazers, you are groundbreakers. And I want to ask, is there a way that the pediatrician can actually identify this or look at it? Because kids, they're taken to the doctors age 3 months, 6 months, 9 months, and all that. Because now we have a lot of young parents that might not be able to, maybe pay attention as necessary to be able to identify, these abnormalities. And some of them actually, they lead to learning disorders. So I think
Absolutely.
I'm just wondering, how can we get pediatricians to actually take this as part of the routine, what they look for, what they check for when kids come for their regular routine, the
Wellness
doctor's
checkup.
visits?
Yes.
Yes.
Mm-hmm. Well, the parents, first of all, let's use a young mother as a case study here. A young mother, let's say this is the first baby the individual is having. No experience of raising babies before. the first thing that mother should do is to give the best gift to that child. And that best gift is breastfeeding. If you can breastfeed that baby very well, and the baby can latch, that is, the jaw was not underdeveloped inside the womb, the tongue is not tied to the floor of the mouth, everything is normal, that child will grow up without any complications related to underdeveloped jaw. Because just the mechanism of breastfeeding alone causes the jaw and the muscles and everything to develop normally to full potential. So the first 6 months of life of that baby is the most important foundation that a mother can give to their babies. So if you miss that, well, the pediatricians then will observe that the baby is constantly choking, that the baby is having chest infection, the baby is a mouth breather, these are things that pediatricians will observe. If the baby is a mouth breather, the pediatrician will observe it. If the baby has a tongue tie, the pediatrician will observe it. If the baby's teeth are crowded, the mother must observe that. They say, my baby's baby teeth are still crooked. Why? This is then you need to ask for help. Even if pediatrician sees that, they may not see that as being an important thing to focus attention on. You need to take your child in. If you observe a child that has baby teeth that do not have spaces between them, baby teeth must be spaced. Even though the teeth are very tiny, there should be enough spaces for each tooth to stand by themselves, and there's space in between adjacent teeth. If you don't see that in baby teeth, there's problem already. So that means you need to see a pediatric dentist who can then say, I can take care of this, or I'll refer you to somebody who does it better. An expansive orthodontist will be able to do it. And that's when the introduction of growth guidance appliance can be used for that baby. It's custom made for them, but it is going to guide the tongue to be in the right place, the lips to be in the right place, and the jawbone to form appropriately. So if the parents can pay attention, if there's tongue tie that the pediatrician didn't observe, the mother can tell any appointment or call the doctor's office and say, please, I observed that my baby's tongue is not lifting up. That is, it looks like my baby's tongue is tied to the floor of the mouth. The baby cannot lift the tongue. Or I can't lift the tongue even if I'm trying to, check the mouth for, health. Then the pediatrician will help the mother or the parents to say, okay, let's find out who can do it. Some pediatricians might be able to do the frenectomy in their office, and some might refer you to ENT surgeon, but ideally they should be referred to a dentist. If a dentist cannot do it, they can refer the patient to the child to an oral surgeon to do it. But this is a simple procedure for those who have laser in their office. It's a few minutes procedure, although it's expensive, but it's a few minutes procedure, and the baby it doesn't have any kind of complication that will come after the surgery. So since it affects not just the jaws, it affects the brain development. And you are talking about learning. Most of these children, because they continually have interruptions of, oxygenation to their brain, the brain is not well formed the way it should be. And I can tell all of us that at 3 years old, the brain size and development is 70% of the adults. So anything between birth and 3 years old and that affects the brain will have a long-lasting side effect or complication.
Thank you so much. Appreciate that. I think if you know any pediatricians, refer them to watch this session of Medical Mondays because they will learn a lot. We did not learn this in medical school, and I'm going to leave it there because we're not dentists. And it's not even a fine line, it's a huge line right there. So thank you so much. This concludes again a CME section for tonight. So it doesn't mean that if you have any questions to ask about the teeth or what Dr. Ajagbe said, you can still ask it and it will be answered. But the CME segment is over. And now we can talk about other things. And before we go to other things to wrap up, I just want to say that the Lord charged me to bring people together to praise Him and to testify to His name. If you have any testimonies, you are welcome to please participate in our praise worship and testimony session on Saturday. It's virtual. It starts at 1. It usually ends at 5, 6. We used to do it in person till 2020 when it went virtual. It's an amazing time to, praise God together. And again, if you have testimonies, reach out to me. If you don't, once you show up virtually, you just text and you will be allowed to share your testimony. I will be sending the link out during the week for all of us to just come together and do something different. And that is really fulfilling than learning about prevention. That is prevention too, though in another sense, in the spiritual sense, I believe. And again, thank you everyone for your well wishes. Today is indeed my birthday, another year, and I praise God. See, I have testimony already that the Lord gave me another year, and I'm grateful. Like I said, I share the same birth date with our honorable rep, the first ever Nigerian American representative in Washington, D.C., Dr. Oye Owulewa. And yesterday, my youngest son took us to dinner. And Dr. Ajay, if you please share the picture, we had so much fun at the Swahili village in DC. So you can see that's my son at the top, that's Honorable Oye, and myself, on my left-hand side. And my niece, actually it was my niece and my son that took us to dinner. My niece was a surprise. I didn't expect to see her, but she was there and we had an awesome time. I also want to appreciate my sisters, Madam VP, Madam CEO, Madam Lara Okunubi, shocked me, surprised me. I got home and in front of my house was this huge flowers with decors that she, all the way from California, sent to me. Oh my gosh. So, okay, let me explain what this is. Because they all seem like all together on that screen. To the right, you will see it's your birthday, happy birthday, with the huge flowers and my favorite color, purple vase from Madam VP. And on the bottom, these 3 things, believe it or not, were from Dr. Cap. Dr. Caprice sent me a mug, purple mug on the right, and a spa bag with everything I need for the spa. I just want to say thank you. I have a lot more gifts from my children and friends, cards from well wishers, but I just want to appreciate, I want to appreciate everybody. There'll be too much to put here. I just quickly sent this that I had pictures of to Dr. Ajay to help me put up. So thank you very much, Medical Mondays family, for your love and for your kindness and for appreciating God in my life. I appreciate you. Thank you.
Can we say congratulations to you again?
Happy birthday to you. Happy birthday to you.
Happy birthday, dear Dr. O. Happy birthday to you. Yay. You all don't give up your day jobs though, because we can't sing.
No, you did. You did awesomely well. Thank you.
Happy
And thank you, Dr.
Happy
B.
birthday.
No, Dr. B, don't remove that. I love it. I love it. Happy birthday.
Happy
Oh,
birthday.
Happy birthday.
Happy birthday. Many happy
thank you. Thank you so much.
Happy
May the
birthday.
Lord bless a new
Glory
age.
to God.
Yes.
Congratulations.
Blessings, blessings.
Yes.
Thank you.
Dr. O, can I share your joy with you too?
Please.
My birthday was November 12th, so I'm a few days older than you.
Oh, wow.
Wow.
And I had my first granddaughter November 1.
Oh, my God. That's beautiful.
Congratulations, congratulations, many congratulations. I mean, it's one after the other. To God be the glory.
I can already
Congrats.
tell. So excited
And
about it.
I have a sister. I don't know if she's on, Mrs. Bemi Adams. Her birthday was yesterday, November 17th.
Wow.
Miss
President of
Mr. Bemi, are
Agbo.
you on? Are you on? Her birthday was yesterday, and Sister Grace Obebe, her birthday was the 4th, November 4th. So we have lots of November children. It's really and the, Oye, Honorable Oye told me yesterday, he asked me what time I was born. I have to go look at my birth certificate because I never looked. And he said that he was born at 11 a.m., that if I was born after 11 a.m., he's older than me.
Wow.
So I said, okay, I have to go check. And we have to put time difference
Oh my God.
into the whole play of things, because he was born in the US, I was born in Nigeria, so we have to figure that out.
Yeah.
Thank you so much, everyone.
Yes, ma'am.
And till we meet next week, I want to ask that we all please stay safe. Thank you so much,
Yes,
Dr.
ma'am.
Ajay. I see all
Next
of
week,
these fun
Monday.
things in the chat box. Thank you.
Business as usual with a bunch of bureaucrats in Washington, and they will resist.
Happy birthday,
Thank you
Dr.
all.
O.
Thank you.
From Dr.
Thank
Booker.
you.
Yeah.
Thank you, my sister. I'm going to have somebody to come help me pick up the peppers. So
Okay, sure.
Yes,
I'll be
yes.
home all week. Just call me.
amazing gift, organic peppers. I love it.
They're hot.
Happy birthday, Dr. O. This is Vinci.
Yes, ma'am.
Blessings, everyone.
Happy birthday. Happy
Happy
birthday.
birthday, ma'am.
Happy
birthday.
This time next year.
I'm dancing already.
Amen.
Yes,
Amen.
Yeah.
Many more.
In Jesus'
Amen.
name.
In Jesus'
Amen.
mighty
I
name.
receive that. Amen.
Grandchildren, oh, good
Many
wife.
more.
Amen.
For
Yes,
your
Lord.
for your
Amen.
men.
Amen to that. Thank
Yeah.
you. Thank you. Amen. Amen.
For the men, we'll be celebrating them.
Yes.
Yes.
Amen.
Yes. Yes.
Amen.
Yes.
The status quo
Yes.
Congratulations.
Amen. The same thing.
Good night.
Thank
Enjoy
you.
your
Okay,
night.
Aaron, enjoy your
everyone.
Yes, ma'am.
evening. Bye.
Have a blessed
Bye.
weekend.
Happy
Yes, ma'am.
birthday.
Happy birthday. Have a blessed new year.
Yeah.
Thank you.
Bye.
As
Have a
well.
great evening, okay?
Thank you.
Bye.
Please do the same.
Happy birthday, Mama.
Thank
I'm,
you.
I'm sending you my virtual amala.
With Begri and Ewedu.
With complete and all the
inside
all
and
the
inside, all the inside of the meat.
and then all the trimmings. So.
Okay.
Thank you.
Thank you.
I'm
Thank you
sending
for
my
everything you've done. God bless you.
Oh, but that Juby's birthday is coming up, November 22nd.
Oh yeah.
You know that's my our papa now.
My Jesus. There's so many fantastic scorpions on this call, on this platform.
Yes. Yes.
God bless you.
God bless you, ma.
Amen. And you too. Appreciate you. Dr. Ajagbe, thank you for a great presentation.
Thank you, Dr. Ajagbe. I like your spelling out your full name. That was beautiful.
But the
Thank
one
you.
but Braveheart is not his name. I don't know how I put that in. For CME program. I'm like, don't let us ding you. For other programs is allowed. For CME, not allowed.
Now, with reaction, we have positive
We
contributor.
like Oluwole.
This is with us. I love your idea.
That's his full name.
There's a mandate to get our economy on track, interest rates lower,
get our economy together.
fix our borders immediately.
Have a blessed night, everyone.
Risk. Towns are safe and secure.